So I grew up here and then I left. I went to the University of Indianapolis and did my undergrad in business originally. I was groomed, pretty much, sorry Dad, to be a business owner, to be a Ford dealer. And then I went on a missions trip with a couple of the guys that are here, and we went to Ecuador, and it was the place that I met the happiest people I've ever seen in my life. And nothing. And then we came back through Chicago, and I'm not saying anything about Chicago in particular, but Americans were rather miserable and insufferable at times. And I asked myself, what's wrong with us? Because the people that I just saw for a week were the happiest, most at peace, poor people. And we have everything here, and something's not working. So I changed my major that summer to psych, and did my undergrad in psych at UIndy, and then my master's in clinical psych there as well. So I say clinical psych because the focus of that degree was on the severe mental illness, to diagnose specifically what are we dealing with. And then I built a specialty in clinical addictions after that, once I got into the field. So I finished up there. I did my internship in Lawrence Township in Indianapolis, K through 12, in developmental psych to begin with. Then I went to a private practice and did a lot of drug court work, intensive outpatient programs, aftercare, outpatient mental health. And then I went to Newcastle to do community mental health, where I did schizophrenic groups, began my suicide evaluation trainings for the jail, the ER, intensive outpatient programs, aftercare. And then I went to Marian University for 5 years and did the counseling in their department as part of the counseling program. And then I taught graduate and undergraduate classes while I was there, while I was also doing private practice at Southside Pastoral Counseling in Greenwood. And then I've been in private practice ever since. So I've been around the block. But where I'm at this point and where I've built my specialties in particular are mood disorders, suicide evaluations, grief, and addiction, unfortunately. Chemical addiction is what I know the most about. We're not going to talk a lot about addiction tonight. There are a couple pieces that it does apply when we talk about suicide, but we're going to jump right into grief, because that should be the thing that most people can relate to, because we all have elements of grief in life, but it's different. We're going to talk specifically about death tonight. There's a lot of other forms of loss and grief for jobs, stage of life, and we'll get to that, a touch on it at the end, but specifically death. When you think about grief, this is the definition I really like. Grief is just love with nowhere to go. And for anybody that's lost a loved one, we use language like, there's a hole in my heart, there's an absence in my life, there's something missing. And the question is, what's missing? Is it the individual, is it the memories? Or is it our inability to reconcile the reality that exists with the story that we wrote for our life? That is the essence of grief. It is not about the outcome of the stages of grief that we'll go through, but the process of reconciling the story that I wrote for my life, the way it was supposed to go. We do this for our kids, don't we? The moment we have them, we've already dreamt through where they're going to get married, where they're going to live, where we're going to follow them, what we're going to do, how well they're going to do it, all the games we're going to see, all the trophies they're going to have, and rarely does life play out that way. So how do you reconcile? And that's the part most people struggle with. They get stuck in one of these stages, and then it becomes dysfunctional. Not only can it become dysfunctional, it can become clinical, where it requires expert intervention. So I love this diagnosis, and we think about grief as just love with nowhere to go. Then how important is love? Back when the Soviet Union collapsed in the 80s, around 1989, some researchers went over to Romania. They were looking at the institutionalization of young children in orphanages. Okay, so when Romania collapsed after the dictator Nicolae Ceausescu was dethroned, we had 170,000 kids institutionalized in orphanages. So as we went there and we're researching how did this impact their development, well, what they realized when they walked in the room, the first thing they noticed, it wasn't the environment, it wasn't the smell, it was the sound. It was silent. And we're not talking about a nursery room of 10 kids. We're talking about an orphanage. And if you know anything about kids, they're not quiet. But this was silent, and that's what struck them. So why are they silent? Under these conditions, only half the kids, they're short-staffed, half the kids get food, clothing, shelter, their bare necessities met. The other half not only are getting the food, the clothing, the shelter, but they're getting picked up, they're getting interacted with, they're getting loved. And the question is, what are these kids that don't have those things, what are they doing? How are they developing? And the reality is, they didn't meet their growth milestones, they didn't meet their developmental milestones, they're not building language, their fine motor skills are delayed. We have what we call infantile depression. They don't respond, they're apathetic. I have no hope for someone to come when I cry, so why bother? To the point that I have no will to live, even as an infant, it's an instinct. I'm going to reject food, I'm not going to eat. And they fail to thrive. Then they die. And that's what we saw. Versus the kids that got interacted with and loved and cared for, they verbalized just fine. They met their milestones, they grew, they interacted with one another, they responded to cues well. So when we talk about how important is love, it is from the moment we're born to the day we die. But that's not our culture. Our culture says grow up, get over it, you shouldn't need that, you're needy, you're codependent. And we misuse these pieces of language because codependency originated in my field of addiction. And now we've globalized it to say, well, people are just needy. You need to grow up. You shouldn't be so dependent on another person. And especially in our culture, we're a hyper-independent culture. Whereas if you look at other places in the world, as I've worked with people from all around the world, university setting permitted me opportunities to work with people from Germany, Egypt, Nigeria, China, Germany, Brazil, Mexico. I mean, I've worked with people from all kinds of different places. And the reality is, it doesn't matter where you're from, what your culture is, what your religion is, what your background is. People are people. We're more alike than we're different. Our needs are universal. They don't change. So what do we do when a child is first born? Where do we put it? And I used to be a teacher, so I like interaction. This is going to be uncomfortable. I'm a therapist. My job is to make people uncomfortable. So what happens when a baby's born? What do we typically do with the infant right after it's born? Put it skin to skin with mom. Why? It's relaxing, it's soothing, it's connection. That's the heartbeat I've known this whole time. And does it stop? No, they cry for it, they want it, they need it. It's a need, not a want. So, if we actually look at the neurobiology of this research in Romania, if you can see this, the brains, these are functional MRI scans of those infants, those orphans from Romania. On the left, you have a perfectly healthy brain. And what we're looking at is the level of activity in the brain, in the different regions of the brain. We want bright colors. We want the reds, we want the oranges, okay? We want the yellows. Those are good, healthy expressions of activity. When we start to see deficiency in activity, we're talking about the blues, the blacks, or the kind of grayer areas. In the temporal lobe, specifically, what's being done there is sensory intake and expression, and your limbic system, which includes your amygdala, which is a lot of your emotional center. It should be nice and glowing on the left, like the healthy person, but these infants on the right have little to no activity. So this speaks to the power of nurture. When we talk about nature versus nurture and what happens to the brain, we're literally changing the neurochemistry and functioning of brains. And this is an example of infants, but this also applies to adults and abuse and drug use. There's little to no activity because they weren't engaged with, they had no hope, there's no expectation, their senses are delayed. And so this is a really good example of the damage that can be done by your environment. Now, thankfully, there's something called neuroplasticity. Neuroplasticity is the brain's ability to be resilient. When I look at an MRI scan in research of a meth addict, near the rear of the brain, we're going to talk about the occipital lobe, we're going to see areas that are nearly inactive, like completely inactive, dead zones, damaged by meth use. If we look at their baseline MRI and then do one at 3, 6, and 12 months with pure abstinence, no use whatsoever, we'll see it to begin to light up again. We'll see some blues at 3 months, 6 months. We'll start to see some yellows, eventually some greens and some reds. Because over time, your brain has neuroplasticity, the ability to build new synaptic connections. It learns to communicate around areas that have been damaged. It does not mean that it's going to go back to what it was, but its ability to heal. When you have a brain injury, for one sense, say a person has an accident and that area of the brain for sound is damaged. What's near sound? Sight. So that is going to compensate in that area of the brain and wire around it to encroach on that area that's not being utilized and function at a higher capacity. It strengthens that sense. The brain finds a way. It's amazing how we're designed and how well we adapt, even from a neurobiological standpoint. So this is a reality of how resilient we are and the damage that we can take place from our environment. And when we think about grief, this is the statement I want you to really remember, that grief is the inevitable tension of an unmet need. We've already defined that love is a need. It's an inarguable need. But the question is, what are the needs that we're meeting in lieu of that essential need? So Dr. William Glasser is the theorist that I follow probably the most. My background, my training was in cognitive behavioral therapy, dialectical behavior therapy, psychodynamics, and motivational enhancement therapy. Those are the 4 theories that I primarily work from. But this one encompasses a number of theories into 5 simple needs. Love and belonging above all else. When we think about the school age years, what is our biggest obstacle raising kids? What's their crowd? Who are they hanging out with? What are their influences? Now it's primarily social media. But we need love and belonging or acceptance. Now the question is, that requires people, by the way. You have to have that need met to meet the other needs, or we attempt to compensate for that need pursuing these others, meaning power. You can't have power if there's nobody to have power over. You can't be free if there's nobody to be free from. We need people. You cannot survive alone forever. That's why solitary confinement is the greatest punishment in prison. If you spend enough time in solitary confinement, you go insane. We misuse the idea of insanity because in addiction we say repeating the same thing over and over, expecting a different outcome is insanity. No, insanity is losing touch with reality. And when you're isolated in prison, in solitary confinement for an extended period of time, you lose touch with reality. And you lose your mind. Then the last one being fun, that we pursue fun at the expense. We need fun, we need other people to have fun. I think about Castaway, Tom Hanks. Why did he create Wilson? Right? No fun dancing around the fire alone. So we create Wilson to laugh, to play, to converse, and to have hope. So there's this inevitable tension that I'm probably pursuing one of these other needs in my grief at the expense of love and belonging because I'm stuck in the grief process. So we've talked about how important love is, but we've done a horrible job of defining it. The Greeks have really tried. They came up with a whole bunch, right? Agape being love of God and the world and others. Eros being the romantic form of love. Philia being where we get Philadelphia, brotherly love. So they came up with all these different versions. It's not a very good single definition of love. And then the Bible talks about a love all the time, right? We're going 1 Corinthians. Anybody want to quote the most famous love? It's patient, it's kind, it's gentle, right? Great qualities, characteristics of love. Is it a comprehensive, clear definition of love? No, we summarize it to say God is love, right? Well, then define that. Who is God? We do a horrible job of defining what we're even supposed to do to love. But this definition, ironically, written by a psychologist, Dr. Perkinson, says love is the active interest and engagement in another person's growth with empathy. When you read that definition, who do you think of? Does that sound like God? Does that sound like Jesus? Okay. He actively was so interested in us and came down to engage with us so that we could grow beyond the old law, feeling everything, and probably more than most of us will ever feel. Like, this is the best definition for people of faith. And I always qualify this because we're a faith-based practice. We don't push a specific religion or doctrine, but we always end our intake with what role, if any, does your faith play in your life, and what role do you want to play in this? So for people of non-believers, I'd say this doesn't necessarily apply to you. I still think it's a good definition to work from. You don't have to necessarily apply to Christ. It just happens to describe Jesus Christ, by the way. Okay? But what does it mean to love through empathy? We talk a lot about, well, you need to be empathetic. But what does that even mean? So many years ago, goodness, probably 16 years ago, I went through a lay counseling called Stephen Ministry Training with Indian Creek Christian Church. And they had this awesome image of the person down in the pit, the person in crisis that can't get out, and then there's us. And so sympathy would be the person that you're walking along the street and you see somebody homeless. And you're like, I have no clue what that's like to be them, but here's $1. I'm sympathetic, I'm going to keep on going, I did my part. The over-empathizer is the person that says, you're homeless, let's go buy tents, there is a park, we're going to sleep in it together, we're going to get food together every day, I'm going to live with you. Don't have a clue how we're going to get out of this, but you're not alone, I'm down here with you, and we're stuck. And we have programs like that. It's called enabling. Thus, the real idea of empathy is rooting yourself to something grounded in truth, unshakable, unbreakable, and tying yourself to it, to not risk your safety and your well-being when you're trying to be a resource and not a rescuer. That's one you can take away. Be a resource, not a rescuer, when you're dealing with people in grief. So you're tied to it, but you get down in there a little bit with them to say, yeah, this stinks. This is hard. This is painful. I'm going to throw you a resource, a line to get out of it. But you have to choose to grab it. You have to take a step. And I'm not going to forfeit my safety or my well-being or my mental health in the process. Now that's healthy. And that's a healthy boundary. And if you've never read the book Boundaries by Dr. Townsend and Dr. Cloud, they're two Christian psychologists, it is the most well-sold book on boundaries ever. They've sold millions and millions and millions of copies. And they have a variety of books on boundaries, from parenting to with teens to marriage. So this is a great example and opportunity to think about boundaries, dealing with people in grief. How far do I go down the rabbit hole with them? As a lot of times you have good intentions, but half the time we're making it worse, or we're not helping really. So let's get back to this needs argument. So, what does it look like when we're pursuing power? What does that look like from the standpoint of what is power? Because that's a broad term. Power comes in many forms, such as money, titles, things. What about freedom? If I'm not pursuing people and I'm pursuing these other things, what does it even look like? Such as, there's a big deal right now. There's complete communities out in Alaska, Arizona, Nevada, where it's a commune of just trailers and motorhomes and people that just want to get away from all the rules. There's a lot of people that prefer isolation at the expense of relationships. Survival. What does it look like to compensate to survival, fight, flight, or freeze? These are the people that look angry. These are the people that are fleeing from your invitations and offers because they're just literally in a state of survival. because I don't know how to relate to you. You get to move on with your life. My life feels over. I've lost the most important thing in my life. Or there's the people that just want to have fun. Okay? And that's probably one of the most common things I hear in clinically is, I deserve to be happy. I just want to be happy. And if you're going to chase happiness, that's dopamine, and lots of ways to get it. There's some healthy ways to get it. We don't usually choose those. And they lead to a lot of other dysfunctional things in life. So we have to recognize, and we have to be honest with ourselves about what is the need that I'm actually pursuing that's preventing me from moving forward in my grief. But we're talking about emotions, we're talking about love. Maybe I'm just being dramatic. Maybe emotions are just for over-dramatic people. They need to learn to suck it up, right? Get over it, move on. This is how powerful emotions are. I have experience with a client, PNES, psychogenic non-epileptic seizures, okay? There is no way for a person to differentiate just observing a real grand mal seizure from a psychogenic non-epileptic seizure. You have full-blown convulsions, you've got teeth chattering, rigidity, eye rolling, spasms, gurgling, all the sounds, all the sights, all of it. Until they are scanned to look at their brain to see if a seizure took place, you don't know what you're dealing with. But PNES, there's nothing occurring in the brain that is actually a seizure. It's a full-on psychosomatic representation of an emotion. That's a very powerful illustration of how strong emotions are. Because that person thinks they just had a full grand mal seizure. They're sweating, they're exhausted, they're thirsty, they're sore. You worry about a fall, a head injury. They've got bruises. It feels like a seizure, and it is a conversion disorder. And we say conversion because it's a conversion from your emotions to your somatic, your body. That's how real emotions are. There's a reason we have an entire area of law that are crimes of passion. People act out irrationally in emotional states. So I'm just saying this is not dramatized. This is very real. So for people that are actually going through this cycle, I'm biased. I lean into the 5-stage policy. I know that there's the 7-stage approach. I think it's a bit redundant on the first stage and last stage. So this is what I lean into. This is what you can typically expect with people. Denial, it's the shock. It's the disbelief. I can't believe this is real. It's not real. There is such a thing as called preparatory grief, where we have somebody with a prolonged illness. You grieve early on that this can be an inevitability. You already start the grief process. Your denial takes place earlier. So when death does occur, you're typically at depression. Okay? You're much later in the game. Anger. In our culture, anger is not okay. If you express anger, if you get loud, you're aggressive. You're a bad person. You need to be subdued. You need to be self-controlled. Anger serves a purpose. One of the things that I teach the most often in therapy is emotional vocabulary. I want people to recognize that there's a big difference between saying I'm annoyed, I'm irritated, I'm frustrated, I'm angry, I'm irate, I'm enraged. Those all mean different things, and it's incredibly valuable what words we learn to use. But we have vilified anger, and we don't give people permission to express it. And that's a problem because it's going to come out. And it's going to come out through addiction, drinking, violence, recklessness. How many DUIs have I treated in 15 years simply because they were angry and they went for a drive? Rather than somebody saying, you're okay, it's okay to be angry, let it out. We used to have this concept of a Bobo doll years and years ago. It looked like a giant bowling pin. We'd have kids hit it, foam bats, all that. That's not the goal, to teach people to just condition their response to violence. That's not the goal. But if you want to go chop some wood, that's pretty productive. If you want to go for a walk, that's good. If you actually want to talk, that's like A+, good for you, but no offense, most guys don't know how to do that. So you have to find an outlet for this or it will come out. And to think about anger leads to stress. What are some of the ailments of stress? Do you all live stress-free lives? No, but we sure pursue it. We all live for retirement, right? So I harp on anger a little bit because we suppress it so much. Bargaining. Bargaining is where we're ready to make a deal. This is my addict that gets caught that says, I will go to the meetings, I will do whatever I have to, just don't leave. We rationalize and bargain with God to say, if you just heal him, if you do this, I will never miss Sunday again for 4 weeks. Right? Those bargains never last. Depression is the inevitable. Depression is the recognition that this is real. You can no longer live in the denial, the anger, the bargain. It's setting in. And ultimately, acceptance. And we're going to get to actually what that means here in a little bit. All right, I mentioned earlier there's a lot of different forms of grief. Not just loss of a loved one, but what about loss of a job? Bankruptcies, legal fees. How many guys in here, you don't have to raise your hand, your wife probably will for you, tie your identity and your value to your job? And you lose it. It's outside your control. How big of a grief in an identity crisis is that? Loss of relationship. This includes divorce, a breakup, they move away, whatever it is. Military. Okay? And we've seen in divorce, if you look at the brain scans of individuals of divorce, the trauma that occurs in their brain for divorce is equivalent to losing a long life partner. Okay? It's that traumatic to the brain. Loss of freedom, mobility, and health. What's it like to have an injury or a health episode that restricts your ability to do what you typically do? How do I handle a college athlete that has spent their entire life and then has an injury and can no longer play? When we think about Andrew Luck, all the injuries he had, right? He walked away from how many millions of dollars? Because he recognized what was most important to him. He built a new identity, and he grieved through it. Did a ton of therapy. He is the poster child for some really healthy mental health choices. And then loss of opportunity. So academic and athletic. COVID exposed something really interesting. What's it like to be a senior during COVID and lose out on your senior prom? What's it like to lose out on your final season of athletic eligibility because you know you're not going to college to play? But what's it like when you're struggling to adapt to online learning when you're an in-classroom learner? Your GPA suffers, thus your academic scholarship offers suffer. The number of opportunities that shifted and changed for our youngest generations, it was profound. And we don't really appreciate it because we're like, nah, they're resilient. They'll get through it. No, they didn't. I saw more suicidal high school and college kids in 2020, 2021 than I have in 15 years combined. They were hopeless. What's the point? I can't be with my friends. I can't do anything. I've lost out all these opportunities. What's the point? And do you think we have enough beds for pediatric and young people? I promise you we don't. We're way understaffed on that. So there's a lot of different forms of grief that we fail to appreciate. So we've covered what's the value of love and the stages of grief, the recognition that we have needs and that there's this inevitable tension between unmet needs and our primary need of love and belonging. Then how do we actually grieve? The goal of grief is to reconcile the story that we have written for life with the reality that exists. How easy is it, though, to live in denial? Denial is the disbelief in the reality that exists because it's so different from the story we've written. It's such a disparity of what I'm in versus the story I wrote. That's what denial is. Because I see reality, I do see it. I have no clue how to tie that in, to stitch it together to the story I wrote. And then good old anger. This one hurts. Anger is self-righteousness towards the disparity because we inherently believe life should be fair and just. And for people of faith, that's what we kind of live for, like the judgment day. Like I've heard plenty of sermons on hellfire and judgment. We have. I grew up in it. But you don't get that in life. I worked with the criminal justice system. I train crisis intervention officers. When we talk about suicide, I will say this, it's not in the slides. If you ever have a mental health crisis that you do need law enforcement, specifically ask for a crisis intervention officer. That is a program throughout the state that we train for a week. I went through the program with IMPD about 16 years ago, but I train twice a year on addictions for a number of departments on addiction, and then they talk about psychiatry and all this so that they know how to interact with people that are having a mental health episode versus just treating them like a normal person that's difficult. So crisis intervention trained officers, it's a valuable term to learn. Anger is a self-righteousness towards the disparity because we inherently believe life should be fair and just, and it's not. I've worked in the criminal justice system. It does its best, but it's ran by man. We're flawed. It's unjust. It's unfair. If that's what you're living for, you're never going to get it. So how do we grieve? Through bargaining? Well, bargaining is the desperation to hold on to a story inconsistent with reality. If I can just have a shred of what was, it won't be as big of a jar for this new story. I want to be able to just take some of it with me. That's where we talk about object relations theory. I want to take an object that has a meaning and transpose it into this next stage of life to feel like it's still a part of it. And that's a coping strategy. And depression is the edge of acceptance, the acknowledgement of this reality. And we talked about that slightly earlier, that to be depressed, there has to be an acknowledgement of the reality that's taking place. Because it is sad. Somebody's gone. Somebody that you loved. Somebody that you sat, when you came home, you talked to, got a hug from, watched a show with, ate with, slept next to, vacationed with, built memories with. That is sad. And here's the real question, and this is the challenge for the faith communities. How long, on average, do people keep contacting the grieving? We're there for the funerals. We're there for the wake. There for the burial. We've got meal train for 2 weeks, maybe a month even. That's impressive. What happens after 2 weeks to a month? Silence, on average. We are called, as people of faith, to grieve as a community. But here's the reality. Life doesn't stop when somebody else's life does collapse. We've still got kids in multiple sports. We've got travel for work. We've got deadlines. We've got our own drama. We've got our own struggles. I don't have time for this. Because that's how we live. Not necessarily how we're called to live. But it is how we typically live. So 2 to 4 weeks. And then the silence kicks in. The phone calls stop. The texts become fewer. And that's where the depression starts to set in, about 4 weeks. And it doesn't take much to fall into clinical depression. We're going to get into the criteria. It doesn't take that much. That last step of acceptance, we have to build a new story. So based in a new hope that drives purpose. Hope is the biggest predictor of suicide risk. A lack of hope. And when we think about people of faith, isn't that where you draw a lot of your hope from? Isn't that interesting that, and that's usually one of we call it protective factors. People of faith have more protective factors inherently because they have something to look forward to for hope. But we let go of it. It's interesting. All right, so how do you actually support a grieving person in your life? We're going to talk about do's and don'ts. And if I offend, I should have started here. If I offend you, that is not my goal. I apologize. I offend a lot of people. I am blunt. I have to be. I get lied to for a living. I say that addicts lie to themselves before they lie to anybody else, but they just lie to me more. So, if I offend you, I apologize. Do's, okay? Be present. What does that mean? Does that mean go and sit with them, say the right things, do the right things, play cards, do games, all that? No. It means be present. How many of you are comfortable with silence? $15 Mississippis. How many of you were uncomfortable? How many of you were annoyed at me? Imagine sitting somebody for 30 minutes in a quiet room, just in silence. Do you think that that matters to them? In their state of grief, there is nothing that you have to say. There's nothing you have to do. The reality that they're not alone when they feel absolutely alone, that simple fact is more powerful than you will ever know. When I had to respond to certain death events in the community, there's no expectation. There's nothing I can say to change that reality. There's nothing I can do to heal the wound that just took place or the shock. It's the reality of I'm just going to sit there with them and let them grieve, cry, scream, say whatever they want, to have the invitation to say and do anything they want. It's just be there. And we don't know how to do that. We are a 24/7, constant, instant gratification, stimulation society. That's not what people in grief need at that moment. Okay, bring food. Meal trains, all that's great because in grief, there's an immediate appetite suppression typically. They have difficulty eating. If they have the food, it's amazing how many people say, I'm so grateful I had a frozen meal, I didn't have to cook. Come month 2, month 3, they add up and they make a huge difference. Offer to cook, offer to do errands, like the little things, the laundry, or just pick up all the things that seem to take their trash down for them. Makes a huge difference. Those are such menial things to them at that state that it's not even on their radar. And to do that, they won't forget that you did it. Invite them. So this is the interesting part is we invite them a lot in the beginning, and then they say no because they're grieving, they're angry, they're hurting. We don't put them in context. We're like, nah, they just don't want to go. They don't want to stick in the mud. They don't want to be there. I'm just going to stop inviting them because they're no fun. They're just going to say no again. Put them in context. Okay, if they're hurting and they're in that survival mode to fight, flight, freeze, typically flight, don't stop inviting them. Eventually they will break. They will come if you continue to invite them. But don't put it in context. And then finally, listen and reflect. How many of you are good listeners? A few? All women. Thank you. Oh, thank you. There's a guy. Cool. All right. We do a horrible job of listening. We don't teach people how to listen. I love imago therapy. It's a form of relationship therapy where we do active listening skills. And I make people uncomfortable for a living, so I make them sit knee to knee and talk. And the guy actually has to look at her, and she has to use as few words as possible. And he actually has to reflect back exactly what she said without his interpretation or his rebuttal, because it's usually the rebuttal. And then they have to verify that that's actually the message that they intended to send. We are horrible communicators. Not only are we already bad communicators, now we just text. People send memes to each other on the couch. Isn't that funny? Ha ha. That's date night. That's how, and that leaves so much room for interpretation. But that's what we do. And we were already bad at it. So when I say listen and reflect, not only listen to them, give them eye contact, when they're saying all the stories and the memories, reflect it right back to them. Oh, that sounds like a fun trip to that place, doing that thing with that person. And that reinforces the reality that that story was true, because the last thing they want to do is forget it. They're trying to hold on to every last memory. That's why they're sharing it. And if you reinforce it to them, it helps. That's empathy. All right, so when does grief cross that boundary into clinical depression? Like I said, it's not hard. Depressed mood for more days than not for 2 weeks, in combination with loss of interest or pleasure. Weight gain. When we talk about weight gain or loss, we're talking about 5% body weight off of your baseline weight at the time of loss. Okay? So it's not an intentional loss. It's I can't eat, or I'm compensating with a lot of sugar to get that dopamine to feel good again. Because what follows dopamine is serotonin. Dopamine's the gotta have it neurotransmitter. Okay? Food, sex, drugs, that's exercise. All those are releasing dopamine. Serotonin is what follows. It's the got it. The contentment. And that's where people that are depressed, that's why we give them SSRIs, selective serotonin reuptake inhibitors. What we're doing is we're manipulating the way the brain communicates to increase serotonin levels so that they feel more content. But by doing that, oftentimes we're putting a floor on how low they feel because we're artificially putting a buffer there with the medication. But a lot of times there's a side effect where we also kind of put a ceiling on how good they feel. And they don't feel the euphoria or the joy as easily. And then they reach out for some dopamine to compensate in the form of drugs or other things sometimes. Unhealthy things. So that's what I mean by 5% on the weight. Insomnia, hypersomnia, inability to sleep or sleeping excessively. When we say not sleeping enough, less than 7 hours. Now granted, some people's schedules are a luxury to get 6 hours, and we get that. You're still sleep deprived. That's called denial. We can talk about it. Hyperinsomnia, more than 9 hours. Psychomotor agitation or retardation means that I'm so lethargic that I have clients that can barely stand up, that can't lift their arms off the couch. They're so depressed. Fatigue, that goes along with, can overlap with psychomotor agitation, but for fatigue and lethargy, I don't have energy. Feeling worthless or excessive inappropriate guilt, okay, can be survivor's remorse if they were in an accident and they survived, the other person didn't. Decreased concentration, inability to focus, potentially thoughts of suicide or death. And we're going to get into the difference between passive and active suicidal ideation, because here's the scary thought. Thinking about death and suicide is quite common. There's a big difference when it leans into active suicidal ideation. And this is the first requirement is that it has to cause clinically significant dysfunction in your life. Okay, occupationally, socially, personally, like there has to be some degree of dysfunction, and it just takes 5 or more of these. Okay. Not hard to do. The treatment for clinical depression, the best outcomes we know come from pairing medication with therapy. Okay? So if you just give a medication, you have about 40 to 60% improvement. Okay? 40 to 60% of people improve in 6 to 8 weeks. I believe 6 to 8. Yeah, good memory. Okay. 6 to 8 weeks. So those are pretty good numbers if we just give them a med, but what we're doing is we're masking the symptoms, we're not treating the problem. It's a Band-Aid, because once they stop, the likelihood that the symptoms return is very, very high. Where if we just give them therapy, it's actually a pretty low chance of improvement when medication is necessary, when it's truly a clinical depression and not just situational. But if you pair them back together, therapy and medication, it's about 80% chance that it's going to get better and not recur when you discontinue. Those are pretty good odds. So there is a benefit to it. Some of the challenges to that, access to therapy, knowing who to go to, what medications to get, okay, where to go, how expensive it is. I mean, if you don't have insurance, good luck. It's hard. But there is real benefit, and it doesn't have to be lifelong. So not everybody works from the model that you have to see somebody for 2-3 years. So most short-term therapy is 6 to 8 weeks. And you can see significant improvement. What does the treatment actually look like? Well, the best definition of therapy that I've ever heard is that therapy is a mirror to see yourself. And I don't want to butcher this. All right. Therapy is a mirror to see yourself without all the distortions and filters we use to cope in unhealthy ways. So think of it this way. When you look in the mirror, typically, you're using an Instagram filter to see a better version of yourself with a bunch of rationalizations, excuses, distortions, to say, this is what I want to see about myself, because I don't want to see all the other stuff that's really there. My job is to remove all that so that you actually hear yourself and see yourself raw and honestly, and it's not fun, okay? And then you do something called transference, and you get mad at me, and I know it's not me, and then we work through it, and it's a whole therapy process. It's wonderful. So the actual treatment for, there's trauma-focused CBT, and there's some brief dimensions to CBT. It's cognitive behavioral therapy, and this is the most evidence-based and most widely used approach in these areas. What that looks like, okay? If I drop a hammer on my foot, and I get angry, is the emotion. And then I act out my behavior is yelling and hitting. What am I angry about? I just dropped the hammer on my foot. What am I angry about? Any guesses? Pain? Is that what you're saying? Pain's slow. Okay? You ever have a paper cut and not realize it until you see it and then it hurts? Pain is slow. We can manipulate pain, we can cause pain, block pain very easily. It's the instant, the moment it happens, there's an immediate thought. You idiot, you screw up, you failure. It is instant. That's what's driving the emotion of anger. Because in the exact same scenario, I drop a hammer on my foot, and I have an emotion of humor and a behavior of laughter, what's different? It's the exact same situation, what's different? It's that instant thought. Oops, I make a good TikTok, you know? It's a completely different perception, rooted in what we call a cognitive triad. Dr. Aaron and Judy Beck, they came up with this theory, and they said that this cognitive triad of beliefs about the world, ourself, and others is our lens in which we interpret situations. Now, I think they're short-sighted, and this is my disclaimer. I put God up there by world because for people of faith, God is a reference of the good and evil that exists in the world. And so that adds to the lens. So for example, some beliefs that I hear frequently. I'm unlovable. Men can't be trusted. I'm never enough. Those are core beliefs that if that is your frame of reference, what do you expect your emotions to be? So that's what we do in therapy. And here's something to think about, and I apologize if this offends you because this is an easy out. You make me feel is the worst grammar in our language. Because you are the situation. Cannot make me feel the emotion. You can do something, potentially stupid, that is triggering something, a core belief within me, that is leading to this emotion. It is far more accurate to say, when you do that, I feel this way. Because it's triggering an insecurity, a fear, a wound. That's more accurate versus just putting it off on someone else that they can't really own. Now, granted, there are people, we're pretty good at knowing how to cut people down verbally. We know their wounds, we know their weaknesses, and that can be misused and manipulated, but it doesn't change the reality that people can say, sticks and stones, words will never hurt me. That kind of framing, it's true. Because if I have a completely different belief about the world, myself, and others, it does not dictate that what you do is going to achieve that emotional outcome. I mean, there's people in the world that you can say anything to, and they really don't care. Like, it's not going to bother them. All right. So hopefully that makes some sense of how to be helpful to people in grief, recognizing that there's that unmet need of attention, of which need am I addressing, power, freedom, survival, fun, at the expense of the relationship, the love and belonging, and potentially how to care for those that are grieving in your life. And also what depression looks like. All right, are there any questions? No? Keep rolling? All right. If I'm going too fast, just tell me to slow down. All right, suicide. Now this is the area that I treat a lot because we don't know how to engage it in everyday life. 1 in 12. 1 in 12 people in the United States have a substance use disorder. That's what we call it. That includes abuse and dependence. Okay? That's 28 million people. 28 million. If you have a family with an addiction history, you know, that percentage is higher potentially likely in your life. Okay? But when we're talking about suicide, we don't do a good job of differentiating overdoses and suicide. But when we include those numbers, the CDC says 186,763 deaths in 2020 involving chemical substances. That's both intentional and unintentional overdoses. 186,000. That's a good-sized city. And I have treated many people that have intentionally taken many doses with the full intent of dying. I have treated people that have had 7 Narcans to bring them back from a heroin overdose. I've had people that have died 3 times in 12 months and been brought back. Not only that, now, not only do we have a fentanyl crisis, and if you don't know what fentanyl is, it's 100 times more potent than morphine, 50 to 100. We now have tranq, which is xylazine, which is an animal tranquilizer, in 90% of the opioids being confiscated in, let's see, the last one I read was Philadelphia, and I believe Indianapolis. When I trained them in the spring, they said in December, I believe it was around 10 to 20% was testing positive for xylazine, and by May, it was like 80 or 90%. So it's already here. Now, the reason they do that, the reason they call it tranq, is because it's the zombie drug. It lasts longer, and they literally look like a zombie. They'll end up just posing in the middle of the street in a position of rigidity. They're just there. That's what we're up against. And how many of those people are dying? Well, from suicide, intentionally, a lot more than we'd like to admit. Also, we have 46,000 deaths simply by suicide by other means. Okay? 46,000 suicides in the United States, according to the National Institute of Mental Health. Here's a horrible one. Men are 4 times more likely to complete suicide. I say complete and not succeed. That's old language. It's not a success to complete suicide. It is just simply the completion of the act. And men, our highest risk men, are white males over the age of 65. They are extremely dangerous and lethal. Now, the one that we don't like to talk about is this last one. Suicide is the second leading cause of death in 15 to 24-year-olds in the past 10 years. When we talk about 10-year-olds that are attempting overdoses on medicine cabinets, trying to hang themselves in their closets because of bullying, just in the last year, I'm aware of 2 young teenagers that took their own lives due to bullying, cyberbullying, the blackmailing that's taking place. Males in particular are engaging in behavior that is very easily exploited and blackmailed, and they're so ashamed of that behavior that there have been a significant jump in attempted suicides for young males. We don't talk about it. And how do you talk about it with them? They are so ashamed. But we have to. We have to find a way to talk about it. Active versus passive suicidal ideation. Okay? When I'm talking about active suicidal ideation, we're talking about how specific is the plan. If I'm working with a teenage girl that says, well, yeah, I want to die, and I've been to the creek with this limb that hangs over, and I've practiced tying the knots with the rope that's in my room in my closet, and I've been there, it's quiet, nobody will find me for a day or two, written out the note a few times. Like, we have to go to the hospital that day. That's a guaranteed admit for at least 48, 72 hours. If I'm talking to a person, because that person has a plan, a very specific plan, they already have the means to do it, being a rope, a knife, a weapon, something, medication. Access, it's easily accessible. They don't have to travel far. It's not something that's unrealistic. Also, is there a history of attempts? If they've tried before, this is an equation. In my role, I'm doing an equation of adding all these things up to a level of risk. And if there's a history, that's a big signifier of elevated risk. Just already. Intent. When we're talking about intent, what's the level of intent being that this is here, this is accessible, I've put a lot of planning into it, versus I don't want to be here anymore. I just want to be gone. Okay? Have you done any planning? No. Have you spelled it out? Have you practiced it? Have you rehearsed it? Have you dreamed about it? No. Your intent's reduced. And then hopelessness. The degree of hopelessness is the biggest predictor. And one of the kind of backdoor questions that I will encourage you to think about is, how do you ask, what are your plans for the next holiday? What are your plans for fall break? Not just this weekend. This weekend's really big. People are horrible. A lot of people are horrible at making plans for weekends. But what about for a holiday or a trip? And so if I'm dealing with a suicidal college student and they come in and they say, I just want to die. I'm done. I can't do it. Courses are too hard. My boyfriend just broke up with me. I'm done. I'm like, okay, all right. And we talk about a few minutes more, and I'm like, you had mentioned a couple of these people, and maybe you were going to take a trip at fall break. And they're like, yeah, we're going down to Florida or this or that. I'm like, okay. And we don't make a big deal about it. It's a very subtle comment. But I already know they're future-oriented. They're planning something in the future. They're hopeful. And it's a very subtle test that you don't have to hone in on to gauge their hopefulness. A future-oriented person is not actively going to kill themselves. That's the silver lining. So that passive suicidal ideation also, I don't want to be here, maybe something a bit more dramatic. I just want to jump off a bridge, or sit on the train tracks. There's a degree of plausibility, but it's dramatic and a very not typical statistically. What about surface level self-harm? This is what it depends on, is where's the self-harm? But there are certain locations on the body that when we're trying to hide the cutting or the friction burns and things like that, more so the cutting, they can nick an artery that they don't realize how close they are, that they might think is a safer location to do it. So directionality of the cut depends, because if you go certain directions, it's a pretty lethal, quick death. And the depth, how much scarring, how many scars, all those things indicate, well, they've done it quite a few times, so that reduces the level of intent, potentially. But we have to educate ourselves a little bit about where we can see it and what they're doing, how they're doing it, what they're using. Potential risk for infection using rusted razors or other things. What about risk-taking behaviors? This is passive, where I'm just going to be a speeder. I'm going to go 80 miles an hour in the car. I'm a hot-headed teenager, and I'm just trying to be reckless. Or I drink and drive, and I realize I shouldn't have, but it's really not an intentional suicide attempt. Or emotionally burning relationships, where I'm just pushing everybody away. This can be a risk factor, but it's not usually a good indicator of intent for active suicidal ideation. All right, we're in the home stretch, and this is where I'm going to try and make this as real as possible for you, unfortunately. This was Tara Condell, and she completed suicide. January 31st, 2019. I'm actually going to read you her suicide note, because I want you to actually be in the mind of a person that is this depressed and what it sounds like. So she writes this letter, okay? So stay with me. I hate the word bye, but see you later, maybe. I've written this note several times in my head for over a decade, and this one finally feels right. No edits, no overthinking. I have accepted hope is nothing more than delayed disappointment. And I'm just plain old-fashioned tired of feeling tired. I realize I am undeserving of thinking this way because I truly have a great life on paper. I am fortunate to eat meals most only imagine. I often travel freely without restriction. I live alone in the second greatest American city. She lives in New York. She's referencing San Francisco is her first home, which is the best to her. However, all these facets seem trivial to me. It's the ultimate first world problem, I get it. I often felt detached while in a full room of my favorite people. I also felt absolutely nothing during what should have been the happiest and darkest times in my life. No single conversation or situation has led me to make this decision. So at what point do you metaphorically pull the trigger? And she did. So she was a registered dietitian, 27 years old, in New York. And yeah, January 31st, 2019, she completed. The key there is hope, hopelessness. There was none left. But what does it also tell you? That she wrote that letter repeatedly over 10 years. When people kill themselves, it is not an impulsive plan. Okay? It's an impulsive act. When a person decides they're going to kill themselves and they're ready, that's the impulsiveness. I'm going to drive to this location, do this thing with this object this way. That's the impulsive piece. A suicide is rehearsed and thought out and reviewed and refined until I've got a high degree of confidence. And the degree of research that people I sit with have gone into to complete with confidence, that tells you about their level of intent. How to do it, what gauge, where, to reduce pain, to guarantee that this is going to happen. I'm not going to survive. All that information is easily accessible, even to our kids. So how powerful is hope? All right. Regardless of the ethical issues with this research, I'm not going to get into that rabbit hole, it still has value, okay? And the point of this research is, it's Kurt Richter, they did this rat study. So they put rats in a jar of water to see how long they could swim. And they last about 15 minutes, they tread water, and then they drown. But they thought, what if we change a variable? At about 5 to 7 minutes, let's pull the rat out, dry it off, let it rest, feed it, then put it back in. How long does the rat survive? How long do you think the second rat survived? 15 minutes, 30 minutes, an hour, 2 hours? How long do you think? 60 hours. Think about that. When you give somebody a reprieve or evidence of hope, this is war. This is a war strategy. When you give your military personnel just the hope that reinforcements are coming and the encouragement, they will fight for you to the bloody end. And they'll do it a lot longer than if they never have the slightest bit of hope. You give them a little reprieve, a little backup, they will fight much harder. And that's what we learned from this study. So the value concerning suicide and depression is if you give people just a moment of reprieve, they can fight longer, typically to find a way through it or get help to get through it healthier. And we use something called the Beck Hopelessness Scale, which is just a 20-item questionnaire that gives us kind of a baseline statistic and measurement of how hopeless they are. And it's a valuable tool. But you can do this just in everyday life by just giving people a reprieve. What about single moms with 4 kids? What about single dads with kids? Or what about people that are grieving a loss of a loved one from COVID? Speaking of COVID, has anybody thought about how hard it was to watch somebody die through a nursing home window because they couldn't be inside with them? They weren't even given the opportunity to grieve. Or the people that couldn't go into the hospital room because only 2 people were allowed, and a mother or father didn't get to say goodbye to their son because wife and child was there, only 2. There are these huge gaps in opportunities to grieve that adds to people's hopelessness. Okay? So then what's the path to hope? That's what we really need to know. Grief is a process, not an outcome. Sounds so therapy. And I always said, grief is the reconciling story that we have written with the reality that exists. But the biggest problem with our story writing is that we are almost always the main character. So how does your story change when God is the main character and you become a supporting character? Think about that. Think about your story for just a minute. Your life, your story, your goals. Where does God fit as a character in your story? Is he the main character? Is he a supporting character? Is he a background figure that nobody even really notices, but supposedly he's there in the movie? He's there. He's a tag along. How would your story change if God was the main character and it wasn't about you? Would that change your goals? Would that change how you live? Because this is, I say this observationally, the majority of our culture is the main character. We are the main characters. God is not the main character. He's not even really a supporting character most of the time. He's a background figure. He might be the lighting guy sometimes at this point. He's just happy to be there. And you know his name sometimes, or he's the guy that got you coffee because he answered the prayer request. That's where he fits in your story, potentially. So if you want hope, where are we seeking it? From ourselves? The main character is us. That's where we're trying to seek it from. God provides a big picture perspective in a world dominated by single moment perspectives. Because when you step back and you make him the main character, you're no longer looking at the moment. Mindfulness and here and now thinking are buzzwords in my field and in positive psychology and current self-help books. There's a lot of value in recognizing the here and now and being present. But when you fixate on just that and me, you don't learn anything from looking back at the past, and you fail to think about what's the point of the future, the hope. And so there's value in it at moments, but we live in it so much at the expense of learning from the past or realizing the hope of the future. And there's no longer fear of the unpredictable when you trust that God is truly in control. So think about this. When I taught abnormal psych, we always talked about the difference between the unpredictability versus the uncontrollability. If I give this example, if you're standing on a train track, what's worse? I can predict that the train is going to hit me. I know when it's coming. It's on schedule. So it's predictable, but it's completely uncontrollable what I do to respond to it. So I have no control about the predictable event that's coming. Is that worse than this? Not knowing when the train is coming, unpredictable. It's going to happen, but it's unpredictable. But I recognize I can control what I do when it comes. Which one's worse, the first one or the second? The first one. It's terminal. It's an inevitability. That powerlessness that people feel, it is overwhelming, and powerlessness is a horrible feeling. It's torture. But when you recognize life is the second scenario, the train's going to come. I don't care how good your plans are. Like, I I'll own I had a little maybe OCD, anal retentive tendencies. I had my 6-month, 1-year, 5-year, 10-year plans, exactly what I wanted, A, B, and C. But life will happen, inevitably. I met most of my goals, but you have to realize that the train's going to come, but I have to recognize I've got some controllable things I can do to how do I respond. Maybe not have exactly how I'd like to respond, but I can still do it in a healthy way. And when you recognize that God's the big picture, that there is a there, how does that change your choices in those situations when we're trying to self-medicate, cope in immediate gratification ways just to get through moments of grief, despair, depression? Okay? When you recognize there is something to come and a big picture, and that changes a lot of choices. It filters out a whole section of opportunities that are right there. So, some helpful questions to learn. Do you have thoughts about wanting to end your life versus do you have thoughts about hurting yourself? We commonly use this language of hurting yourself, but it means something very different. Cutting, burning, choking, self-harm of some kind. I need you to learn, do you want to end your life? That's the question we're trying to answer. It's uncomfortable, it's not fun, it's scary, but it is language you need to learn. Do you have thoughts, what are your plans for this upcoming holiday? That's another one that we talked about, that is a really easy, passive way to get future-oriented thought. What is your plan to end your life? Use that specific language. I want to know how detailed it is. How much thought have you put in? Do you have access to the means to fulfill that plan? If there's weapons in the house, this is the time to lock them up. It is fascinating to me how many people leave weapons in the home, not locked up, because they say, well, I need to keep my place safe. Or I trust that we've taught them better than that. That is an ignorant statement. I'm sorry. When you're dealing with a person that is already having difficulty kind of reality testing about what's going to happen if I really do this, because there's this disbelief that if I pull the trigger, it's really going to accomplish it. It's an ignorant statement to think that they have the self-control or the mental stability to assess the risk there. Are they taking their medications as prescribed? If you're dealing with somebody that is already medicated, are you taking your meds? Like, that's my first question. And 9 times out of 10, well, I missed a few doses, or I wanted to wean myself off a little bit, or I didn't think I needed that one. I mean, I've heard plenty of different variations of that. So that's what they're going to do if you put them in the hospital, is they're just going to start them back on the med they were already on. Are they giving away items or trying to convey goodbyes? This is a passive way of exhibiting suicidality, that I'm going to give away things of meaning, not just cleaning up the house. I'm giving away things of meaning. And do they have a history of suicide attempts? We already said that that's a huge risk factor. This is where we're going to end. It's football season, okay? Game plans. And we think about suicide and grief, and we've talked about our essential overarching need for love and belonging. Which game plan are we playing? God gave us a very clear, cut and dry game plan. What is it? What's the greatest commandment? Amen. You got an A+. Good. Love the Lord God with all your heart, all your soul, all your mind. Love your neighbor as yourself. 3 pieces. Love God, love your neighbor, love yourself. It's connect with God, because you can't love him without connection. Connect with others. Community, ecclesia. The church is a gathering of people, not a building, not an institution, not a philosophy. It is people. And connect with self. You know, I think Jesus was rather selfish, going off on his own, ditching the guy, spending time with the Father. He was really just kind of an introvert, apparently, right? Taking time off, just lazy in our terms today. Only a 3.5-year ministry. Well, how many years you already got? 2? You got a year and a half left. So this was the plan. But we forget about the other game plan, and it is the exact opposite. And we play it a lot more than we play God's game plan. Because the opposite is divide from God. Look around culture, look around the communities. Would you say that people are connecting with God or completely dividing from God? Divided. For all kinds of reasons. We make up reasons to divide ourselves from God. Divide from others? Are we unified? Are we unified in our belief in the basic tenets of faith? Or do we bicker about all kinds of different beliefs or little details? Guy on the cross next to him didn't get baptized. I'm just saying. He's in trouble. Those are the details that we do. I'm just saying. And the divide from self. Judas. This is the greatest example of dividing from self. It's suicide. This is the home run for Satan. He loves it when you do the job for him. Those 65,000 suicides in 2020 were all home runs for him. Okay? And here's the reality: which game plan are you playing? Because you're playing one or the other. You're not playing both. And think about your story. Am I connecting with God regularly or just on Sunday? Or let's schedule them in because we've got trips here, and we'll hit this small group in that season because the fall, hey, small groups are starting back up, by the way, right? It's that time of year. Sorry. I might make a lot of people mad. You'd think I'd be used to it by now. My sister will say it's been since birth, but this is the reality. Which game plan are you playing, and where are you in your story? So the challenge questions I'll leave you with, because I really want to try to be on time. That's the therapist's job, is to end on the hour. How are you meeting your prerequisite need for love and belonging? From the definition that we agree upon, that love is the active interest and engagement in another person's growth with empathy. Not only is that an illustration of Christ, but how do we raise our kids? Do we raise them? Are we interested in them? Do we engage with them? Do we play with them? So that they grow and mature, so that they're not still living in the basement at 45? I mean, that is the goal. And feeling a little bit of what they feel periodically. What are the obstacles to you loving or being loved? Because it's not everybody else's problem. Okay? Periodically, you have to look at yourself. What's the obstacle to you loving or being loved? And lastly, are you the main character in your story, or is God? And how would that change your story if you reassign the roles? Are you willing to do that, because it will change your story moving forward? All right, I told you when we advertise this, I'm going to give you as many resources throughout the state as I can. So I moved from Indianapolis up. These are adolescent mental health resources. Epworth in South Bend, that's ages 13 to 17. You can take pictures of this. I am going to post the video of this, so you'll be able to freeze frame all of these resources. Options here in Indy, ages 11 to 21, Michiana Behavioral Health, Oaklawn. So the only one out of these that I can truly speak about is Options in Fairbanks. Fairbanks is the best medical detox treatment center in the state, in my opinion. They've got it down to a science, and they do it very well. Eating disorders. I work with both of these locations, Selah House and the Cara Center. Both are excellent at getting people healthy and back into learning their hunger cues and setting boundaries and building accountability, all kinds of great work done there. Residential and detox for addiction. So I am familiar with Sycamore and Lafayette. I don't have a lot of client interaction with them, so I can't speak to them. Like I said, Fairbanks is great. St. Vincent Stress Center does do some. St. Catherine, East Chicago, I'm not as familiar with. Hazelden. Hazelden is the best. It is the gold standard of treatment in the United States. It's the Betty Ford Center. Their philosophy is that recovery is connection, addiction is disconnection. And what I love about Hazelden is their post-care programs. They keep up with all of their attendees. They keep them in the alumni programs. They do them all the time. They do messaging and support care and coaching. It is a wraparound service that treats co-occurring disorders such as bipolar and other things that are occurring with the addiction. It's a great, great program. And then Hickory House in Greenfield I work a lot with just because it's local to me and they've done a good job. Lastly, outpatient mental health. We do have some resources in the very back of the table in the hallway for 4-county counseling. I believe from the way I've read it, they're based out of Logansport, but have some care in all 4 counties. Porter Star, Stark in Knox, Brighter Tomorrows in Plymouth, New Directions in Plymouth, Wabash Valley in Monticello, and I did put myself in there either as a resource or if you do virtual therapy or are comfortable with that, that is something many of us are doing now. And then that's my info if you want to remember it. So that puts me on the hour. Yeah, I'm open to any questions if you have them, and we can pause the video now so that your questions you don't have to worry about them.